I do want to thank the association for the invitation. It is an honor to be here and present in front of you. I was born in Mexico City, where I did my dental school, and then I came to Chicago to do a periodontal prosthesis training at the University of Illinois from 1980 till 82. And we didn't have any windows at the lab, but we had this poster with a goat, and it said, "I'm so far behind that I think I'm first." How many of you will raise your hand and feel that you're successful today if you were practicing the dentistry that you learned in dental school or even your specialty training? I don't believe anyone will raise their hand. Some of the pictures you're going to see have been taken and have been scanned, from slides, and most of them have been with digital computer. None of them have been enhanced to improve the aesthetic outcome, and I'm not getting paid by any company for this presentation. The treatment modality in the 60s, 70s was root amputations, hemisections. So what we did is we put our Superman cape trying to do these heroics and make the cases work. But we knew that sooner or later the tooth will be lost. This was, of course, before the Bryant era. And with the Bryant era, things have changed. So what has taken place is we've seen an evolution with implant designs. Many of them have no anti-rotation. And there's been an evolution also with prosthetic components. And in regard to implants, we see all kinds of screws that are from different companies, different places in the world. Different designs, and the prosthetic configuration depends on where the implant has been placed, many times without a concern on how the patient will be able to maintain those areas or the loading that that implant will be carrying. Here we have two cases, one prosthodontist, a different prosthodontist, and the abutment was not all the way down. We have a different prosthodontist also who did not obtain a passive fit on his prosthesis, and that's how the bone was lost. So the question is, do you know how your implant is being restored? Well, the question is, does it matter? If your implant has been integrated, what does it affect you? Well, your implant is integrated, what's going to take place after? Do you know the impression material that's going to be utilized for taking that impression? Does it make a difference? Will it go to a commercial lab? Is the impression technique important? So if you're going to use an open or closed tray, does it make a difference if it's with a single or multiple implants? These are issues that could affect the longevity of the implant that you had placed. Will it be a stock abutment or will it be a custom abutment? And if the implant is not in a good position and you'll need an angle abutment and you did not line up the flat wall into the buccal, that angle abutment as a stock component may not actually work. Does your restorative dentist know that because he quoted the patient a certain fee? Will the restoration be cemented or will it be screw retained? And when should this be decided? So unless you try to do something beyond what you have already mastered, you will never grow. That's why the treatment modality in the 90s was multi-disciplinary approach. But many specialists did not even communicate with one another. So interdisciplinary approach is very important, and that's why I believe this is truly the key for a successful outcome. As Amsterdam said in 1974, there may be different ways of treating a disease, but there can be one only correct diagnosis. So when you have placed your implant and the implant is integrated, do you know the level of integration of that implant? So you send it to the restorative dentist. If you have done bone grafting, sinus lift, do you know if you should have a provisional for an indefinite period of time? For 18 years, I've used the perio test, and right now I'm starting to use the Ostel unit to determine, not only from a legal point of view, how that implant should be restored. And I think that's very important to do this in this day and age. Still using surgical guides, this is what I got back from the oral surgeon. It doesn't look very pretty and doesn't make me feel good that my guides were not utilized. And the question is, well, this implant is integrated and I finish my prosthesis. Is this a successful outcome? Should we have addressed the tissue biotype prior to the implant placement? A lot easier than dealing with this after. Here I do have to thank the periodontist for referring me the patient. Unfortunately, all the implants are integrated, which we don't say that quite often. So the question is, if you don't know where you're going, how can you expect to get there? Yes, the implants are integrated, but it doesn't really help much. And the patient is expecting to have a fixed bridge, non-removable. Do I have it cemented or do I have it screw retained? So if it's cemented and and I need to retrieve it. How will I do that? So in this particular case, we took a final impression. All the abutments were milled to get a nice fit, nice transition for the final prosthesis, a nice draw, and they were tapped through the lingual. So this we can do in-house. I have a lab technician that can do this for me, and was able to provide the patient with what the patient wanted. If I had been involved at an earlier stage, maybe the design would have been quite different. So here we have lingual screw retained restoration, and some people will say, well, have it cemented. But upon retrievability, sometimes it doesn't come out when you want to. So I do like to have screw retained restorations. And this is how it looks in the patient's mouth, and here the patient is smiling. Was not the only person smiling. The lab technician was smiling when he sent me the bill. It was quite significant. And in this day and age, if I had to do that bridge again, this is pretty much what I will be doing. All is zirconia restorations. And you can have them now even full contour. So things are evolving to how we planned things in the past, and we need to update them with new modalities. And again, still be cautious with those new modalities. We like them to be tested. So we know that experience is not what happened to you, rather than what you do with what happened. So when should we consider the aesthetics and the final restoration? Is it going to be cemented or screw retained? And should these take place at the lab technician's bench? Or should we do this when we take the impression? Or more so, should it be done when we're treatment planning the case? Will the abutments be zirconia, titanium, or gold? Is there position or angulation a problem? Will it be used as stock or custom abutment? Where is the margin location going to be? And what type of tissue biotype we're going to be managing? Will the retention be temporary or permanent? Will it be a screw through the occlusal or a lingual screw design? Have you communicated this with the restorative dentist? I know in many instances you're the guys taking the impression as well, and then the dentist cements the crown and he bills for the crown, which I think is very sad. But if everything is done as originally planned, we can see here a patient that needed a tooth extracted. With careful extraction and implant placement, we have in the proper position. And with a well-designed system, we have a conical design that's giving me the right tissue profile. So all I have to do is measure the tissue height. And if the profile that I like is the correct one, I can just take my final impression and finish it up. If I need to modify this tissue profile, I may have to do this with a provisional and widen it slightly so the final restoration has a natural contour and natural look. In this particular situation, I was able to utilize a stock component and cement the crown. And we made the crown a little bit lighter because the patient wanted to bleach. 3 years later, the patient has not whitened her teeth. Here we have a 46-year-old female who was very unhappy with her upper crown, and she wants a long-term stable result. And this treatment was started in 2003. Contemporary implant dentistry is more than providing a patient with aesthetic restorations that have natural contours, texture, gingival margins are the correct ones, and the restoration is going to blend the way we want to. But for us to have a successful outcome, we need to treatment plan our case in a reverse pathway. And we do this by visualizing the final aesthetics and working towards a healthy foundation. And that crown is going to have the proper soft tissue support that was created with a provisional. Here we had a CAD/CAM restoration. But this is what we had to deal with when that tooth was extracted. So we knew that we were behind the 8 ball. The tissue was already higher. And it was really on the surgeon's the problem to build up that bone. Yes, with a provisional, they'll give the proper support. But when we started the case, this is what it looked like. So we knew that this was going to be an issue to begin with, especially that we're dealing with triangular teeth. We already had a small gingival embrasure on that front tooth. This is what the tooth looked like. We wanted to do the super eruption, but the patient came from out of state and did not want it to have the tooth super erupted. This is the final restoration, and this is how the case was completed. So we must visualize that aesthetics from the onset. Here we had a patient that had Maryland bridges that kept coming out, and we like to do our treatment plan based on the brand principle. We tell the patient what the benefits are. Here we said we'd like to do some orthodontics to properly place implants rather than trying to fit the implants in. So we give the patient the benefits of doing orthodontics. We tell the patients what the risk is to do one technique or not to do it, what the alternative will be, And what happens if the patient says no? And with those guidelines, we feel that the patient will accept treatment in a significant easier way. So clinically, we can see that the roots were not in a good position, and orthodontics was quite indicated. So we start with the ortho on the lower arch, and then we proceed with orthodontics on the upper arch, correct the position of the roots on the central, then on the canines, to provide with proper space for that implant. And while we know that the bone is a little bit narrower for one implant, we knew we'll have to deal with restorations that will have to be either customized or cemented or some type of angle abutments. And this is created pretty much with this provisional. We cannot take an impression mostly on an anterior tooth and go straight into the final restoration without understanding the aesthetic demands that the patient has. The question that I have is, do all abutments need to be torque tightened? And I like to do that for single units, and I never do that for multiple units for a bridge, as I don't believe there's a need for it. But this is the final restoration, and we can have an aesthetic outcome that the patient is going to obtain what the patient anticipated in the first place. It was previously described by Dr. Elian, some of the studies that are changing on the distance between implant to implant, implant to tooth. To me, this 3 millimeter rule needs to be revised as it's taking place, because this was done with studies where we knew that we'll have some bone loss on the top threads. And we have implants today that provide better bone preservation. So that needs to be analyzed individually. And in this case, we have two implants that are somewhat close to one another. Prosthetically, we'll have a nice outcome. We can cover the screws with composite. But ultimately, this is way too close. And if this implant had been a little bit more mesial, maybe we wouldn't have this bone loss. And again, everything comes to treatment planning and execution. So decision making is very critical. So I think this is a little bit similar that sometimes we have to deal with clinically. Here we had a 44-year-old male with a vertical fracture in a lower molar. So replacing a molar, it's a tooth that carries quite a bit of load. And this took place in 2006. So this was done through the ACCEPT program to have the patient understand what the problem is. So through this program, we can do numbers so the patient will understand what tooth is missing, how careful the extraction needs to be to preserve the bone, the lamina dura. This is the distance. We have 15 millimeters. What are our prosthetic options? We're going to have one implant that's 5, 6, 6.5, 7 millimeter diameter with some companies, and this is the profile we're going to have. And I finish the crown, the patient will not be happy with some of those contours. Or do we place two implants? And when we do this, we place this on the x-ray or on a picture that we have taken. This is their case, and the patient is more likely to understand their situation, not someone else's. So this is the situation with the patient, the original slide, and as described in the literature, one of the options is, of course, after careful extraction, we understand that two implants here will be quite viable. Here we have two implants placed. I would have liked them to be a little bit deeper, but they're in a very good position. And as I like to have the restoration screw retained, in this case I had some arguments with the surgeon. He wanted them cemented. And I do like retrievability. So we place the two abutments, screw retain. Or should I have restored this individually? Implants are very strong, that's another option. But the patient did fracture a molar. So we need to know that the gingival embrasure is going to be open enough. And here we have the final restoration in place. We cover the occlusal screws with composite. And here is a view of the final restoration. And I believe this was a better approach than having just one single implant, other than the cost, which is pretty much double. And here we have a 16-year-old male where the patient has advanced perio problems and occlusal problems, and he knows he's going to need extensive bone regeneration. So we see the patient smiling, aesthetics is not an issue, but the bite is an issue. And he knows that the upper right side, the molars, he's had multiple abscesses, and there's practically no bone, class 3 mobility on the premolars and on the upper right side. So when we look at the x-ray, we can see there's practically no bone. How are we going to regenerate this lost bone? And what are we going to do with these implants on the lower right side? So we see the patient a few years later, when he decided for me to see him, after traveling all over the country, seeing the previous restorative dentist. And I said, I need to take these implants out. I don't do the removal, but I would like to just unscrew it. He adjusted the bite, and the patient was hesitant. Ultimately, he accepted that this has to come out, and I was concerned with the regeneration of the bone, let alone with the nerve. So the patient was referred, was treated by Dr. Tulani in Paris, and he did the cranial bone grafting on the upper right, upper left, and lower right segment, let it heal for 4 months. Patient was then referred to Dr. Salama. He placed the implants. And with a passive fit, we decided to have everything splinted. And this is the final outcome. And we like the cranial grafts because there's less resorption, given that it's a little bit complicated for some people. So here we have a patient that is 56 years old, extremely apprehensive about the aesthetics, and she would like to have at the end of treatment an optimum result. She had been in biphosphonate therapy for about 5 years, and she discontinued this when we just saw her. Number 8 has a class 2 plus mobility, and she sneezes and the tooth can pretty much come out, so we're a little bit concerned with that. So is the patient. So when we see her smiling, her main concern is that the metal is showing here at the gingival margin, and the lateral, that it's a little bit darker. And we say, well, we know that that's an issue, but we feel that we'll be able to manage that. We look at the panoramic radiograph, everything looks within normal limits, an apical that she had several years prior without any complications from that regard. When we look at her clinically, this is the issue. There's been severe recession, no attached gingiva, and the quality of the tissue around it is very poor. So the question is, how do we restore this case? How do we manage it? What are our treatment options? You know, we're a few hundred people in this room here. We may all come up with different alternatives. So in situations like this, you know, we need to create a team. So we like to look at it from an aesthetic point of view from every possible angle. So today we need to really take photography because we need to analyze this concern that the patient has from every possible angle. And we know that the outcome of this tooth is actually hopeless. So a patient had a cephalometric study done, Panorex, the whole study. So I'm meeting at the orthodontist office and meeting for the first time the periodontist and the oral surgeon who referred the patient to me. And we're not on the same page on how to treat this patient. So the question is, what do we do if the team is not on the same page? It is a problem. So what we know is that we're going to need a soft tissue graft. There's no question about it. I believe we all agree on that. To some extent, we're going to need also some bone grafting because the entire buccal plate had been lost. The problem here is that we need to do orthodontics or no orthodontics, or is it the problem too advanced to do orthodontics? The orthodontist says there's no upside on doing orthodontics, and she's very concerned because the patient had gone under biphosphonate therapy, may not move, even though the rest of the dentition had a plus mobility, and we felt that that was fairly stable. I said, there's really nothing to lose if we're going to do orthodontic treatment. Let's try to super-up the tooth. So after arguing for about 40 minutes, the patient accepted, the orthodontist accepted, we'll do orthodontics. The question is, what type of orthodontics we're going to do? Are we going to super-up this tooth slowly, or are we going to do this fast? What is our objective? Well, my objective was to gain soft tissue to be able to do a bone graft. The periodontist wanted to do lateral sliding pedicle grafts to cover it. And I said, the bone graft will have to be too big, the sliding is too large, everything is going to slough. What's going to happen to the papillas? Where are we going to be? The surgeon was just quiet, he was just listening. So after 40 minutes, orthodontist accepted that orthodontics will be done, and we're not agreeing, and she wants to do it very, very slow. I want to do it fast, because my goal is to gain the soft tissue. So I said, after half an hour of arguing, and the rest of the team is just listening, I said, I'll just step back and let the orthodontist handle the orthodontic treatment. We know we're going to need an extraction, and we're going to need an interim provisional. What the tooth has been extracted is going to be removable. Patients are going to be very comfortable. I tend to do provisional resin bonded retainers, orthodontic wire, to preserve the soft tissue, and the patient doesn't have to have a removable. But we're also going to need an implant, and that provisional will have to be removed. Then we're going to need an implant-supported provisional, followed by the definitive restoration. We look at it from the lingual, from the incisal, and you can see that there was heavy wear, heavy grinding that had to be done when the crown was delivered. So we take out the crown and we see the post. And we look at it from the incisal view, and this is when the patient is in occlusion. My point is that there was not enough lingual reduction for the crown, because this tooth was already in occlusion. Traumatized the tooth, possibly eliminated the buccal plate. And this is what it looks like, the recession from the side. But when we go into the studies from Bramfjord, Ash, Erickson, Schluger, Udelis, over the several decades already, even more recent studies as the last year, there's really no conclusive evidence that occlusal trauma is going to create a parental problem. And that's what the literature tells us. Do we believe that that was the case for this particular case? I'm not so sure. The apicoectomy, I don't think that was failing. There was nothing on the apex. What it is that we do not plan to fail. We do fail to plan. And we hope we learn our lessons. So in this situation, we took out the post. We told the patient very carefully, try not to extract the tooth, create enough retention intracoronally, and I made a provisional. And the patient practically gave me a kiss. She was happy. She says, I'm done. She says, I can smile again. I says, far from it. We know that we're not done, and we still have quite a hurdle ahead of us. So orthodontist starts treatment. Please pay attention on the date, December 07, 9 o'clock in the morning. We have this with digital photography today. So this is what it looks like just after the ortho had been started. And of course, I need to adjust the incisal surface and the lingual surface so the tooth is not under traumatic occlusion. And here we have a few months later. So here we have 7 months later. Is this slow enough for you guys, the ortho? Is that okay? I'm starting to lose a little bit my cool here because that's not what I envisioned. And yes, the problem is still there. The patient is being extremely cooperative. So we continue with treatment. And here we have a few months later. I keep superopting little by little. And here we are in January. Okay, this is already 2009. I think this is slow enough, okay? I'm listening. So February, March, and I'm thinking, okay, how much longer is this going to continue? Now we can see the amalgam on the apex. And yes, the tissue looks actually nicer, but the defect is still there, without a doubt. So the patient comes this morning, April 21st, and I say, this is not really what I had in mind. My thought was to bring the root palatally, to let some of the tissue grow over, so eventually a bone graft could be done. I said, this is just not what I want. So I called the orthodontist. She answers the phone. I said, Sergio, we're done. I said, there's really nothing else to gain with the ortho. I said, you're kidding, right? He says, no, there's nothing else to gain. So I said, okay, so that's your perspective. You tell that to the patient that tells me that she still has a defect. I says, well, we'll try to move forward. And I'm saying, okay, maybe the entire team was looking things in one direction, I'm looking in a different direction, and we need a second opinion. So I believe in second opinions are always, well taken.
He
says, are you crossing the street? The guy says, yes. So worse than not having the correct information is believing that you actually do. So it happens to be a problem who we ask for that second opinion from. I says, that's perfectly fine with me. So I tell the patient, I'm taking over the ortho from this point on. He says, what are you talking about? I says, I've done ortho before, you're not the first patient. So what we did is I saw the patient a week later, and the purpose was to bring that tooth down and correct whatever we have left. So I bring a new bracket, position it more gingival, so we can achieve the superoption that we want. I clear the interproximal surface, and I place a nitinol wire. So the nitinol wire tends to go back to its original position, and it does that very fast. How fast? Well, here we are on April 27, 4 o'clock in the afternoon. And next morning, you can see how the wire is starting to get straighter. Getting to its normal position, we need to adjust the occlusion the next day, less than 24 hours. Purposely, I tilted the bracket. So as the tooth is coming down, the bracket will be engaged in the inner slot with the nitinol wire, and then achieve the rotation that we wanted to obtain. So the patient looks at this. Here we are just a few days later. He says, Sergio, okay, you might be doing your ortho, things are moving nicely, but I'm not very good PR for your practice, just so you know. I says, I know, but we're in the middle of ortho. I says, I just don't like the way it looks. I said, okay, I hear you. So the patient comes back 3 days later. I remove the bracket on the direct provisional because it was permanently cemented. I did through direct bonding, a new tooth, composite, reposition the bracket, and continue with the ortho movement to continue to bring this tooth down, but also correct the position. And you can see what has taken place here in just a few days. So here we are. We started April 27 with the ortho. Here we are May 5th. And this is what the tissue is starting to look like. So a lot of remodeling is taking place in the gingival area. So a week later, we take an X-ray just to follow up where we started. Again, it's not three-dimensional, but we felt that we have achieved pretty much as we want to, because the goal was to have some soft tissue to provide a support for the bone graft. So we see the patient at the end of the month, we let it heal, and we feel that this is about as much as we can achieve with this procedure. And I don't do extractions, I don't do root canals. I like to send those out so I can concentrate to what I like. This is where we started with the ortho, and this was actually achieved in 5 weeks. So the week after, the lateral was prepared to have a root canal with a cantilever onto the central, and purposely this was under-contoured to let more volume of that soft tissue to regenerate around the central. So the patient was in treatment practically 5 weeks, orthodontic treatment. So we let it mature for 3 months, goes to the oral surgeon, and I'm saying, he sends me these pictures a few weeks later. I says, what did you do? What did you do with bone graft? I would have placed the implant right away. He had a surgical guy, says he was not comfortable. He felt that we needed a bone graft. My take is, I'm not the surgeon, so I got to listen to him. So we let this heal for about 2 months, and this is what it looks like 2 months later. Could we have achieved this with any other treatment modality? And this is where we started. So now we have to just wait, let it heal to at least 2 more months. Minimum healing time will be 4 months. And what we had to do is prevent anti-rotation from the provisional. So the lateral was prepared. We don't need the cantilever anymore. I bonded with a lingual wire and composite on the other central. So this tooth will not be spinning. And now we can go ahead and do our planning through digital planning. So what we did is we painted on the same provisional the patient had with colloidal silver, send the patient for a CT. Patient goes for a CT, and this is the results that we have. We can see the bone density that we had, where it was most critical, and start planning. Where should the implant be, what type of implant, the width, the depth, and so on. And this is something that in this day and age, we should really not treat for any anterior case without this planning. And we're happy we're able to do that. We have pretty much the outline of the tooth and decide what is the width of the implant. We know that much wider implants is not the best because sometimes we end up with very thin buccal plate, and that's not the desired outcome. Through the planning, we can move the implants in different positions, mesial, distal, buccal, lingual, start talking about what type of restoration we're going to have. Will it be cemented? Will it be screw retained? If it's screw retained, will be just a large screw onto the main implant. We'll have an abutment. They talked about the one abutment one time. I think it's great, but it doesn't apply to all the situations. So we need to be also practical, even though that's our goal. So a computer-generated guide was designed and placed into the patient's mouth, and the implant was placed. And I would just have to wait. We need to be patient. The question that I have is, are all the implants the same? Well, some people drive a Rabbit, and some people drive a Porsche. They're both German, they're both convertible, but they're not the same. What we know is that all implants work. People can talk about surface texture, shifting, making medialized shifting to do a platform switching and so on, but it's important to know our connections. So we need to know the implant design, we need to know our abutments, it's important to know that interface, and we need to know what the effect is going to be as far as bone preservation and soft tissue response. In conclusion, we need to have a very clear diagnosis and treatment planning. We like to set up that interdisciplinary approach from the onset, and many instances include the lab technician if we're going to need that at the beginning. Vision and communication and execution is critical. And I do thank you for your presence.